Good afternoon, everyone, and I hope you're all charged up for today's Karkande, which is on Code Blue. I really missed the Code Red session last week. I believe it was excellent. So I'm sure they have set a very high bar for the Code Blue team. The previous times that the ICU team performed in Karkande, they were all highly appreciated. So over to today's team. Dr. Arif, would you like to introduce everyone?
Good afternoon, everyone. Welcome you all for this Code Blue scenario sessions. Our team members are all Maria sister. You all know please come. From emergency team, Mr. Bharat, he's acting as an ER doctor, and sister Nitya sister, she's acting as a ward nurse. She's also ward nurse also, and Sindhu will be another ward nurse, and Akbar will be doing the timing, and he'll be acting in this team as a part of session. And an ER nurse will be our nurse from the ICU, sister Kavya sister, and Uma sister also will be acting as a patient attender. Our ICU doctor is here, Dr. Saravanan. He'll be acting as a team leader for the Code Blue scenarios. There will be a mega code also will be running around with the scenario happening from the ward. That will be completely explained by them, and they'll be doing. Sit back and enjoy. Thank you.
வாஷ்ரூம் போயிட்டு வந்துட்டீங்களா? இப்போ பரவாயில்லையா அங்கிள்? படுத்துக்கிறீங்களா? பெட்ஷீட்லாம் போத்தி விடுறேன். ஏதாச்சுன்னா என்னை கூப்பிடுங்க. அங்கிள் என்னாச்சு? ஏன் ஒரு மாதிரி பண்ணுறீங்க? அங்கிள் சிஸ்டர் 2603லேருந்து சிஸ்டர் எங்கள் அட்டெண்டர் வாஷ்ரூம் போயிட்டு வந்தார். என்னாச்சுன்னு தெரியல. எங்கள் அங்கிள் இப்படி ஆகிட்டார் சிஸ்டர். பயமாக இருக்குது பாருங்க சிஸ்டர்.
Are you okay? Are you okay? No response. Pulse no.
சிஸ்டர் என்னாச்சு சிஸ்டர்? எங்கள் அங்கிளுக்கு ப்ளீஸ் சிஸ்டர் பயமாக இருக்கு.
202 ட்ரிங் ட்ரிங். ஹலோ, கோட் ப்ளூ 6th A block room number 2602. கோட் ப்ளூ 6th A block room number 2602. கோட் ப்ளூ 6th A block room number 2602.
அக்னாலேஜ்.
6th A block 2603ல கோட் ப்ளூ சார். 6th A block.
வாங்க போலாம்.
சிஸ்டர் என்னாச்சு? பல்ஸ் செக் பண்றேன்.
கோட் ப்ளூ டீம்
கரோட்டிட் பல்ஸ் ஃபீல் ஆகல. கார்டியாக் டேபிள் வைக்கறாங்க. சிஸ்டர் 1 mg அட்ரினலின் IV கொடுங்க. கியூபிட்டல் லைன் இருக்கா பாருங்க.
Arrival of ICU team and ER team.
ஓகே சார், AED பேட் கனெக்ட் பண்ணுங்க.
ICU team has arrived to the venue in 2 minutes and ER team has accompanied us. Nitisha, I think there's a code blue now. Please take care of the circulation. Check for IV patency. And is there a doctor here?
Yes, I'm here sir.
Can you please accompany here? Dr. Bharat, please take care of the airway. Please secure an EJV. Please give an adrenaline 1 mg bolus. And Kavya, please take care of the CPR, reliever. Basha, please breathe the scribe. Inform me every 2 minutes and 4 minutes. Yes. Doctor, please tell me. Thank you.
Mr. Don, 45 years old male. He was came
Okay.
with complaints of loose stools 10 times. He went for washroom and he was not unresponsive.
Injection adrenaline followed 1 mg followed by 20 ml flush given sir.
Thank you. Okay. First, we need to rule out the 10 causes of cardiac arrest. Was there any oxygen requirement for the patient?
No, sir.
So I am ruling out hypoxia. And how many times did the patient pass loose stools?
So he passed 10 times loose stools, sir.
So significantly there is hypovolemia. Was the BP recordable?
Sir, no, sir. Now not recordable. I given
Okay.
a 500 ml of NS, sir.
Nidisha, can you please give another 5 ml fluid bolus?
Yes sir.
Disha, please give 5 ml fluid bolus. Can you please take an ABG so we can rule out hyper and hypokalemia? How was the temperature?
Temperature was normal, sir.
Okay, in ABG we can see acidosis as well. So I am ruling out hypothermia also.
Okay, sir.
And we need to rule out 5T.
ABG has been sent.
Thank you. Check for the rhythm. Rhythm shows normal sinus rhythm. Is there any pulse? No pulse. There is no pulse. It's in pulseless electrical activity. Continue the CPR. And did the patient have any cardiac abnormality? How was the echo before?
So echo was taken, it was normal, sir, just now.
Okay, how was the chambers?
Chambers are normal.
So I am ruling out tamponade because there was no pericardial effusion or anything. And how was the patient? Was completely mobile?
Yes, sir, he went washroom and he
And the
came
chambers were normal. So I am ruling out thromboembolism as well. I cannot rule out acute MI because it is an acute event. We need to rule out that after doing the resuscitation only with ECG and echo. Okay? Check for rhythm, stop CPR. Is there any pulse? No pulse. Rhythm shows VF. Please shock the patient with 200 joules. Continue CPR till then.
200 joule charge. I clear. All clear. Everybody clear. Shock deliver.
Continue CPR. Bharat, you are doing a good job. Please continue giving 2 breaths for every 30 compressions. And has the ABG been sent?
ABG vandichu, sir.
Okay.
So pH 7.30,
Okay.
PCO2 25, PO2
Okay.
250, bicarb 80,
Okay.
sodium 130,
Okay.
potassium 2.4, sir, and calcium 1.30, lactate was 5.
Okay. It looks like a metabolic acidosis and patient is dehydrated. Bharat, you secured a EJV, right?
Yes, sir.
Please connect 40 milligallons of potassium and 100 ml NS. Nidhisha, please connect and give it to him. And give it at 25 ml per hour.
Sir, 6 minutes over. Rhythm analysis.
Check for pulse. Check the rhythm. Rhythm shows VF.
No pulse.
Okay, please shock for 200 joules. Continue CPR till then.
200 joule charge. I clear. All clear. Everybody clear. Shock deliver.
Continue CPR. Nidhisha, please connect KCL.
40 millicoulomb in 500 ml over 4 hours. Started.
Can you please relieve from the CPR? Sister, can you please relieve Kavya from the CPR?
Sir, 8 minutes over. Rhythm analysis.
Rhythm shows normal sinus rhythm. Is there any pulse? Please stop CPR.
Pulse, sir.
Okay, the ROSC has been achieved. Please secure the airway. Give 2 mg midazolam. Secure the airway. Please do proper suctioning. If you find any difficulty, please let me know.
Injection glass 2 mg given.
Doctor, do proper suctioning.
Suctioning the patient.
Please counsel the attenders. I'll talk while moving the patient.
Inserting ET tube. 7.5. Secure at 22 rhythm. Connect the back.
Bends the patient. Pulse is 65 per, yes, I'll check. Pulse is 65 per minute and BP is 110/70. Position checked by 5-point auscultation. I did an ETCO2, but it cannot be checked in the ward, so we'll shift the patient to the ICU and we'll do a checking. I'll speak with the attenders. Can you please start moving the patient to the ICU?
Yes, sir. Prepare to shift the patient to ICU. To the sidelines. Connect to the monitor. I need standby oxygen cylinder.
கவுன்சில் பண்ணிட்டு ஐசியூ கூட்டு வந்துருங்க.
Okay, sir.
சொல்லுங்க அக்பர்.
Pressure control mode.
ஓகே பிரதர்.
Thank you.
தேங்க்யூ. தேங்க்யூ.
Hello everyone. I'll just give a brief summary of what happened here. In what there was a code blue or the patient was found unresponsive. The first responder, who was the ward nurse, அவங்க வந்து பேஷண்ட்டை பார்க்குறாங்க, whether the patient is awake or not, checking his consciousness level, then immediately alerts the second responder, calling for help. The second responder வந்து first பார்க்குறாங்க, unresponsive இருக்காங்க. The first responder starts the CPR. The second responder calls for code blue. 202 call பண்ணி 3 times வந்து code blue announce பண்ணுறாங்க, which will be going to the ER as well as to the ICU. Then she brings the crash cart near the patient. Crash cart வந்ததுக்கப்புறம் they insert the cardiac table or the CPR board, then give 1 mg adrenaline stat if there is no pulse. Soon after, then they will connect the paddles and check the defibrillator for the rhythm and start ambuing the patient. Meanwhile, the code blue team will arrive. CPR கொடுக்குறப்போ basic steps. The left hand should be in the bottom in the center of the chest, and the right hand should be above the which is the dominant hand should be the above, and the knuckles be folded. The power should be coming straight from the shoulder and not from the wrist or from the elbow. The elbow should be straight. 100 to 120 compressions per minute, 2 breaths for every 30 compressions if the airway is not secured. And about the quality of CPR, high quality good CPR will be containing complete chest recoil. For we will be compressing the chest in the center of the chest for 5 cm, that is 2.5 inch deep, with minimal interruptions and at the rate of 100 per minute with adequate ventilation. There should be no hyperventilation. Complete chest recoil ஆனோம், அது வந்து ஒரு 5 cm டெப்த்தில் வந்து we should watch for recoiling of the chest. And the code blue team members, a code blue team will be containing a person who is securing the airway and taking care of the airway, a person who will be taking care of the defibrillator as well as the drugs, a person who will be taking care of the time, he is known as a scribe, and 2 people for the chest compression and a team leader. So we all were present in the scenario. Basically in ER, OT and ICU, we do not trigger code blue because we have adequate expertise for resuscitation at that point of place. But in non-clinical area like cafeteria, outpatient waiting area, we don't have innate expertise and there is no place for resuscitation. So we scoop the patient and move to the nearby clinical area and we perform ACLS at that time. And in this scenario, while the play was placed, closed loop communication was very much needed. That is, for every orders given by the team leader, there was proper communication or the reverting back from the team member. Like example, I just told the staff to give injection adrenaline. She reverted back like there is an 18 gauge Venflon and I am giving 1 mg injection adrenaline stat followed by 20 ml of fluid bolus, and she reverted back. And the same, I just asked the doctor to secure an EJV. He reverted back saying that I secured an 16 gauge EJV in the right EJV. So the communication will be very closed and the orders will be given by the team leader only and the team member should revert back. I think you all just understood the scenario here, and if any doubts you can just ask me. Any doubts from anyone? Yes sir.
Say, like, how will you decide who's the airway person? Who round the clock there's a team sitting waiting?
Yes sir, round the clock.
Are they doing the routine duty, and then as and when, because you know, if there's some team doing something busy in the ICU and there's a call, how do you decide? You know, you have any people only sort of for this job and round the clock, and then they go for the call?
Can I take this question, Sarana?
Yes, please.
Sorry to interrupt.
You can take the question and you can
Any code blue team needs 6 people. That's a minimum number of people required to conduct a proper high quality CPR, right? See, the understanding at the ward level is that there will be at least 2 nurses already available at the ward level, minimum 2 nurses available. So that is the understanding. So This is only an internal process. Sometimes you can decide there will only be one nurse. So which means there needs to be another 5 more people. In our situation, there are 2 people. So there needs to be another 4 more people who needs to go as reinforcement to complete the code blue team. So the process in our hospital is that because our ER is a small ER team, our ICU is a small ICU team, we don't have 4 people to go from the one single area to go and complete the code blue team. That is 6. So for that reason, the 202 call lands both in the ICU as well as the ER. That's been the existing process for ages here. And whoever picks up the phone first answers the call and they understand where it is, and 2 people leave from that, of which one is a doctor, other one is a nurse. There are already 2 nurses at the ward. Let's assume this situation, ICU picks up the call. So there will be an ICU doctor running, there will be an ICU nurse running. And then again the understanding is that the ER call will get disconnected once ICU picks up. So it's the duty of the ICU to call up ER and tell them that there is a code blue in 5A or 6A, wherever it is. And then the ER team, there is one doctor and one nurse who runs. So this is the expectation in an ideal situation. Now sir's question is there a dedicated team? Is there a dedicated 2 people in ICU, dedicated 2 people in ER? No, unfortunately, for our existing manpower, it is the on-call ICU doctor and an ICU nurse, on-call ER doctor and ER nurse. So let's say 2 o'clock in the morning, ER is very busy. Then there will be one doctor who will be running from the ICU. Instead of sending a doctor from the ER will send 2 nurses. All the code blue team needs is 6 people who are trained in ACLS. There is not even a need for 1 doctor and 5 nurses or 2 doctors and 4 nurses. As long as the code blue team is able to ventilate the patient properly with an ambu bag or maybe with an LMA, it is good enough. There is no need for an expertise to intubate the patient in that. That's the recommendation by the ACLS training. So long story short, we don't have a dedicated team for code blue alone. The code blue team is formed by the on-call ICU and the on-call ER team, along with the area where the code blue happens, with depending on 2 nurses from that area.
So what is the legality of a code blue team? Like for example, the patient doesn't say, what is your responsibility or what is your liability?
Legality wise, the code blue team is so sir's question I don't understand. When the code blue team goes to the scenario, it is a totally new patient for the team. They have not even seen this patient once before. The patient could have gotten admitted through the OP and an elective admission to the ward, and unfortunately has had a code blue. So the ER person doesn't know the patient, the family doesn't know the treating team, everything is new. That is one reason you would have seen Dr. Saravanan taking the history from the nurse from the scene. So at the end of all this, if a return of spontaneous circulation happens, okay, at least we have more time to sit with the family, introduce ourselves, talk to them, get a little bit of story and all that. But if there is no ROC achieved, the patient unfortunately dies in the ward in spite of the resuscitation, then the whole question comes, who's going to pass on the bad news? Who's going to break the bad news, number one? And what is the legal responsibility? These are very, very important questions actually, because it is the totally unknown team which is facing all the brunt. If you have seen our attender, oh my God, you're better than a real attender, ma. I don't know whether you have stopped crying now at least, after the ROC. So it's an alien atmosphere, and legality per se, as long as the ACLS has been performed as per recommendation, high quality CPR has been given, everything which can be tried out at that particular level has been tried out, there is no issues. And whatever good or bad which has been identified after, the primary team and the other consultants would have already been part of the treating team, will be the ones who would take all the responsibility, not the code blue team per se, as long as the ACLS has been performed to the best of its standards.
My last question will be, I understand of late that whenever any resuscitation happens, it happens in front of the patient's relatives. They're allowed to be there to just to see that you're really doing something. Do you allow them in Code Blue?
We generally don't recommend that, but as sir's question is that can the relative see the CPR happening, active CPR happening? They can see, but we generally don't recommend. We explain the family that it can be very unpleasant for them at the time of CPR, and we generally recommend them to wait outside. But we do tell them that, I mean, end of the day, it's all trust, right? I'm saying an antibiotic I'm giving. I mean, a lot of times the relative doesn't check whether an antibiotic is given or not. Likewise, when I say the CPR is happening, the relative who's waiting outside the room has to trust that a CPR is happening. But we have had situations where the relative specifically wanted to do the CPR. We have primed them that it can be unpleasant for them, and there will be a big team of doctors and nurses around, and it will be a little chaotic and all that, and then brought them inside, and they have witnessed CPR also. So if they want to see, they have to be allowed to see. That's the point.
So the other thing is we need to have one person who will be there to look after the attender if we allow inside. Because suppose they faint or something, now we are already just barely 4 of you trying to manage 6 people's job. That time you let the attender in and they faint or something, so that also has to be thought of. If you have someone who can guide the attender in and out, then maybe we can.
Is there another scenario?
Your manager on duty. So they will be communicating with the attender while we are in the process of CPR.
So madam's question is very, very relevant, because if you look at the real life scenario, it will be absolutely chaotic. We say 6 people. If you actually go to a ward scenario, there will be at least 12 people around the bed in that small room with very little space to move around even. And it is very important that there is security and an MOD for crowd control, to pacify the attender, to make them sit in a place and all that. So it becomes equally important that you manage the attender in addition to managing the patient too. Do you have another scenario, or is it over? It's over. So.
Over.
Yeah, I think RF is planning to.
Already summarized everything.
Abdiya, mudichtiya niye?
Mudichita, sir.
The points that just I wanted to make.
Unusual things you face as any unpleasant things you face after the Code Blue, because you are the people who have to respond to them. You have had experience. Are you ready with answers?
AC poichu. Mic le announce பண்ணிட்டேன். The points that I wanted to make again, I'll just probably break it down into clinical part and the non-clinical part of it. Clinical part, fantastic. It is a great exhibition of what actually happens. As he pointed out, the basic things. CPR, doing an ACLS doesn't involve brain. It has to happen at spinal level. அது reflex மாதிரி. இப்போ நீங்க ஒரு 2-wheeler எடுத்து ஓட்டுறீங்க, ஒருவரும் யோசிச்சு அடுத்தது நான் கியர் போடுறேன், நான் ரைட் திரும்பணும், அதனால இண்டிகேட்டர் போடுறேன்னு யோசிச்சு போட்டதில்லை. கற்றுக்கும் போது பண்ணுவீங்க. But then after you become well versed in it, it just happens automatically. You know, you have to turn right. உங்களுக்கே தெரியாமல் இண்டிகேட்டர் போட்டுருப்பீங்க. நிறைய தடவை நான் மதிய கைலாஷ் கிராஸ் பண்ணேன், அந்த அளவுக்கு வேற ஏதோ யோசிச்சுட்டு ஓட்டிட்டு இருப்பீங்க. ACLS has to become like that. It has to be like that. அதுக்கு ரெகுலராக ப்ராக்டிஸ் பண்ணிடுறேன். இந்த 3 ஏரியா சொன்னார் இல்லையா, ER, anesthesia, ICU, இங்கெல்லாம் வந்துட்டு ஆல்ரெடி there are enough doctors and nurses with expertise, and many times ஒரு மாதிரி ஒரு ACLS or a very sick patient ட்ரீட் பண்ணுற ஆப்பர்ச்சுனிட்டி நிறைய இருக்கும். அதனால் அங்கே இருக்கிற நர்சஸ் வந்து கான்ஸ்டண்ட்டாக டச்சில் இருந்துகிட்டே இருப்பாங்க. ஓகே, பட் ஃபார்ச்சுனேட்லி வார்டில் அவ்வளோ அரெஸ்ட்லாம் நடக்கிறது இல்லை. வார்டில், ஓபிடிஸில், டயாலிசிஸ் யூனிட்டில், டயாலிசிஸில் நடக்குது. ஓகே, ஸோ அந்த மாதிரி லெஸ் அக்யூட் ஏரியாஸில் அவ்வளோவா நடக்கிறது இல்லை இல்லையா. ஸோ இட் இஸ் வெரி இம்பார்ட்டன்ட் தட் யூ ஹாவ் டு ரெஃப்ரெஷ் யோர் ACLS ஸ்கில்ஸ் ரெகுலர்லி. எப்படி ஒன்று ட்ரைனிங் நடத்தலாம், பட் என்னதான் இருந்தாலும் மேனிக்கின்னு அவ்வளோ ரியல் லைஃப் எல்லாரும் வந்துட்டு அந்த மாதிரி நடிக்க முடியாது, கஷ்டம் இல்லையா. ஸோ யூ ஹாவ் டு கெட் ரெகுலர்லி போஸ்டட் இன் intensive care on these areas so that you keep up your skills. That is one point I wanted to make. Again, Selvi sister is doing a fantastic job in organizing all the critical care courses. But in the madri patients regular நீங்க resuscitate பண்ணும்போது தான் you become comfortable, then it becomes like your 2-wheeler riding. That is one point. And second point is that ACLS always happens because of some problem. There is a cause. and you have to find out the cause and treat the cause. அது பண்ணாமல் 3 மணி நேரம் ACLS பண்ணால் கூட return of spontaneous circulation வராது. Like in the example பார்த்தீங்கன்னா, it was only a 45-year-old male, but acute gastroenteritis, 45-year-old male, யங்குன்னு வச்சுக்கலாம், ஏன்னா we're all that age, ஸோ அதனால யங்குன்னு தான் சொல்லுவேன். ஸோ அவங்களுக்கு gastroenteritisனால cardiac arrest வருதுன்னா இட்ஸ் ரியலி பேட் gastroenteritis. என்ன காசு? இங்கே ஹைப்போகெலீமியா இல்லையா? பட் ஹைப்போகெலீமியான்றது பொட்டாசியம் நீங்கள் ஏபிஜியில் பார்த்ததுக்கு அப்புறம் தான் தெரியும். அதுக்கு முன்னாடி என்ன நினச்சிருப்பீங்க? 20 எபிசோட் டயரியா போச்சு. இட்ஸ் எக்ஸாக்ட்லி ஹைப்போலீமியா, டீஹைட்ரேஷன். வாட் இஸ் யுவர் ட்ரீட்மெண்ட் ஃபார் தேட்? கிவ் ஃப்ளூவிட்ஸ். எக்ஸாக்ட்லி. ஸோ ஏபிஜி ஒரு பக்கம் அனுப்பிச்சாலும் you have to assume certain things and you have to treat the cause. சரியா? காஸ் ட்ரீட் பண்ணலன்னா 3 மணி நேரம் பண்ணாலும் திரும்ப வராது. ஓகேவா? தட் இஸ் வெரி 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 இம்பார்ட்டன்ட், ட்ரீட்டிங் த காஸ். கரெக்டா? ட்ரீட்டிங் த சார் காஸ் எப்படி சார் கண்டுபிடிக்கிறது? 2 விஷயம்தான். ஒன்று, அவர் கேட்ட மாதிரி ஹிஸ்ட்ரி. ஸோ போயிட்டு அந்த பேஷண்ட்டை பற்றி அங்கே ஆல்ரெடி இருக்கிற அந்த 2 வார்ட் நர்ஸ்க்கு தான் தெரியும், ஃபர்ஸ்ட் ரெஸ்பாண்டர், செகண்ட் ரெஸ்பாண்டர். அவங்கள ஆல்ரெடி செஸ்ட் கம்ப்ரெஷன் கொடுத்துன்னு இருக்காங்க, ஆம்பு பண்ணிட்டு இருக்காங்க. அவங்கள ரிலீவ் பண்ணி வெளியில் எடுத்துட்டு உங்ககிட்ட இருக்கிற 4 பேரில் ஒருத்தரை செஸ்ட் கம்ப்ரெஷன் பண்ண சொல்லிட்டு யூ ஹேவ் டு டேக் அ ஹிஸ்ட்ரி. ஸோ ஹிஸ்ட்ரி எடுத்தால் தான் தெரியும். ரெண்டாவது, யூ கேன் டூ அ விபிஜி ஆர் அன் ஏபிஜி. ஓகேவா? அதில் யூ வில் நோ சுகர் கம்மியாக இருக்கா, அதிகமாக இருக்கா, பிஹெச், அசிடோசிஸ், ஆக்சிஜன் எப்படி இருக்குது, எலக்ட்ரோலைட் இம்பேலன்ஸ் எப்படி இருக்குது. there are many things you can find. So these are the only 2 things. You get the history, do a VBG or ABG. Then find out the cause, treat the cause. Only if you treat the cause, you can get a circulation back. Okay, va? That is important. The last point that I wanted to make is we do regular mock drills everywhere. Correct? All hospitals pandrom. What we identify is that the code blue team varradhukku usually 2 ல இருந்து 3 நிமிஷம் தான், maximum 3 minutes. We have never had மலர்ல அக்யூரேட்டா எனக்கு தெரியல, but in the other hospitals so it may take much longer than 3 ன்னு சொல்ல வரீங்க. we have deployed one team there, sir. So non clinical area code blues will be dealt with by RF. அதுக்காக நீங்க தப்பு பண்ணிட்டீங்க. Let's say 3 minutes ஆகுதுன்னு வச்சுக்கோங்க code blue team. The first and second responder, in lot of actual scenarios also, we have realized that அவங்க அந்த சிச்சுவேஷனை ஐடென்டிஃபை பண்ணுறதே லேட்டாக தான் ஐடென்டிஃபை பண்ணுறாங்க. அந்த அக்செப்டன்ஸ் டினையல் மோடில் தான் இருக்காங்க. இது கோட் ப்ளூ இல்லை சார், எந்திரிங்க சார், ஒன்றும் இல்லை, நல்லா இருக்காரு, பக்கத்தில் அட்டெண்டர் இருப்பாங்க, அவங்க பேனிக் ஆயிடுவாங்களோன்னு சொல்லி ஒரு சின்ன டிலே இருக்கும். அதுக்கப்புறம் நான் இன்னொரு நர்ஸை கூப்பிட்டு வரேன், அந்த டைமில் உட்காந்து நான் பிளட் ப்ரெஷர் பார்க்குறேன். வாட் யூ ஹேவ் டு டூ இஸ் லுக் ஃபார் ரெஸ்பான்ஸ். ரெஸ்பான்ஸ் இல்லைன்னா முடிஞ்சு போச்சு, கோட் ப்ளூ தான். பல்ஸ் இருக்கோ இல்லையோ, ஆல்ரெடி GCS இஸ் லோ எனிவே, ரெஸ்பான்ஸ் இல்லைன்னா have a low threshold to call for code blue. That's my point. It's better to overdo than underdo. பயந்துக்கிட்டு ஐயோ கால் பண்ணணுமா வேணாமா, ஒருவேளை கால் பண்ணி அவங்க பார்த்தோன்னே இது ஒன்றும் இல்லைன்ட்டாங்கன்னா டோன்ட் வரி அபவுட் இட். வாட்ஸ் அ ப்ராப்ளம்? உட்காந்து காஃபி தானே குடிச்சுன்னு இருக்காரு ஆரிஃப் சார், இல்லையா? ஸோ ACLS மெட்டு கால் பொறுத்த வரைக்கும் have a low threshold. It's always better to overdo than underdo. கால் பண்ணிவிட்டு அவங்க பார்த்துட்டு என்னம்மா தூங்கின்னு இருக்காரு, இதை போய் கோட் ப்ளூன் டைம், that's okay, that's all right. But you might end up missing out on one life if you delay even by 2 or 3 minutes. That is one thing. மூணாவது, அந்த 3 நிமிஷம் கோட் ப்ளூ டீம் வர்ற வரைக்கும் it's a precious time. It's a very 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 important time. Brain can tolerate hypoxia only for 3 to 5 minutes, which means என்னதான் ROC வந்தாலும் பிரெயின் சர்வைவ் ஆகுதா இல்லையாங்கிறது நீங்கள் அந்த 3 minutes பண்ணுற CPR-ஐ பொறுத்து தான் இருக்குது. ஸோ 0 டிலே. ஃபர்ஸ்ட் ரெஸ்பாண்டர் போய் ரெஸ்பான்ஸ் இல்லைன்னு தெரிஞ்சிச்சுன்னா யூ கேன் ஒன்லி லீவ் தட் ரூம், லெட்ஸ் சே ஃபார் 5 seconds. அது கூட எதுக்கு? வெளியில் ஓடி போய் செகண்ட் ரெஸ்பாண்டரை கூப்பிட்டு 2602 கோட் ப்ளூ அனௌன்ஸ் பண்ணுங்கன்னு சொல்லி திரும்ப வர்றதுக்கு 5 seconds, let's say 7-8 seconds max. And after that you come back, start chest compressions immediately. இதனை ஏன் திரும்ப நான் emphasize பண்ணுறேன்னா, we are still having scenarios where code blue team walks in and CPR has not been started. Believe me, the mortality comes down from 70% to 10% if you don't do CPR for those 3 minutes. சாரி வளர்றேன், சர்வைவல் 70% சர்வைவல் வந்து அந்த 3 minutes சிபிஆர் பண்ணலைன்னா அப்படியே 10% குறைஞ்சிரும். ஸோ by just doing that CPR for 3 minutes, you are saving another 60 out of 100 people by doing CPR. சரியா? அவ்வளோ இம்பார்ட்டன்ட் அந்த 3 minutes. அதனால ஜீரோ டிலே, டோன்ட் வரி. செஸ்ட் கம்ப்ரெஷன் பண்ணும்போது அவர் தூங்கி இருந்தார், எந்திட்டாரு, என்னம்மா பண்ணுற அப்படின்னு தள்ளி விட்டாருன்னா தட்ஸ் ஃபைன், ஒன்றும் இல்லைப்பான்னு சொல்லிட்டு வேலையை பார்க்கலாம். பட் இஃப் யூ டிலே சிபிஆர், யூ ஆர் ஆக்சுவலி மேக்கிங் திங்ஸ் வர்ஸ். ஓகேவா? இட்ஸ் வெரி 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 இம்பார்ட்டன்ட். I think I've exhausted all my points. Okay. So you asked one doubt. I think I forgot the question actually.
The question I want to ask is, have you encountered any unpleasant situations post cold flu, patient related? There will be crowd, there will be thing, and have you have any experience deal with it?
Many sir, many sir. Most of the times it's family related, so we need to understand their situation also. We need to understand it is totally unexpected. Yes, of course this patient was sick but admitted in the ward, and lot of times this patient would have been talking and walking and eating until a few minutes before it happened. Okay, so adanal it's an absolute shocker. அவங்களுக்கு அதை ஏற்றுக்கிறதே கஷ்டம். ஸோ ஃபஸ்ட்டு பாயிண்ட்டே வந்துட்டு நீங்கள் என்னமோ பண்ணிட்டீங்க, நர்ஸ் இப்போ தான் வந்துட்டு ஏதோ ஒன்று கூட்டிட்டு போனாங்க, அதுக்கப்புறம் இப்படி ஆகிட்டாரு, ஸோ சம்திங் லைக் தட். இல்லைனா நான் வந்துட்டு 1 மணி நேரமாக சொல்லிட்டு இருக்கேன், அவருக்கு கழுத்து வலிக்குதுன்னு சொல்கிறாருன்னு யாரும் வந்து பார்க்கல, அப்போ பார்த்துருந்தா, இந்த மாதிரி நிறைய அக்யூசேஷன்ஸ் ஃபேமிலி சைட்லேருந்து இருக்கும். யூ ஹாவ் டு பி மென்டலி ப்ரிப்பேர்ட் ஃபார் தட். தட் இஸ் ஒன் திங். நவ் intensive care most of the times is well protected. ER மாதிரி கிடையாது. It's not at the entrance of the hospital. It's always 3 or 4 floors above. அதனால we are reasonably protected from all this mob. கூட்டமாக வந்து பிரச்சனை பண்ணுறது வந்துட்டு ரொம்ப 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 குறைச்சல். வார்டு லெவல்லையும் மோஸ்ட்லி அந்த மாதிரி தான். ஓகே, எக்ஸப்ஷனல் சிச்சுவேஷன்ஸ் இருந்திருக்கு, பட் யூஸ்வலாக இஆரில் தான் அந்த மாதிரி ப்ராப்ளம்ஸ் வரும். ஒரு பெரிய கூட்டமாக வந்து ஃபேமிலி 10 பேர் உட்காந்துட்டு நம்மளை சுற்றி வளைக்கிறதெல்லாம் இருந்ததில்லை. பட் we have had situations. Most important thing is your body language and the fact that you tell them that everything appropriate was done. And you also reassure them that yes, survey wala engalukku puriyudu, but we will find out, please give us time solli mob kalachi vidradhu romba romba important. It is very very important. Ena sir solra situation vandu patient is gone. If the patient is alive, you have lot of time. ஐசியூக்கு மூவ் பண்ணுறீங்க, அதுக்கப்புறம் இன்வெஸ்டிகேட் பண்ணுறீங்க, இன்னொரு அரெஸ்ட் ஐசியூவில் போய் வந்தால் கூட ஃபேமிலி இஸ் ஆல்ரெடி ப்ரிப்பேர்ட், யூ ஆர் ஆல்சோ மென்டலி ப்ரிப்பேர்ட். பட் அங்கவே வச்சு பார்க்கும்பொழுது இட் இஸ் நாட் ஈஸி. மெனி டைம்ஸ் இட் கேன் கெட் அக்லி, இட் கேன் கெட் டேஞ்சரஸ் ஆல்சோ. அதனால் it is very important. That is one reason we have included the security as part of the code blue process. எங்கே நடந்தாலும் there should be a security for crowd clearance. Okay, that is very important. If in case there is a question from the family, இப்படி ஆச்சு அப்படி ஆச்சு இப்படி ஆச்சுன்னா, give us time, we will give you explanation for everything. And lot of times the primary surgeon or physician will be very helpful for you. Contact them, get in touch with them, and they will give you vital clues. விடியால 3 மணிக்கு இருந்தால் கூட they ஃபோனை கொடுங்க நான் பேசுகிறேன். Lot of times these families associated with the primary surgeon or physician for decades. அவங்க 4 வார்த்தை பேசினாங்கன்னா எல்லாம் ஆஃப் ஆயிடுவாங்க. That happens, and they have been very very helpful to us in many situations. So you have to think according to that scenario, you will have to take it forward. Okay, to quote I have few, but I don't have time for that. I don't think we have time for that.
Thank you. And I just want to make an announcement before the quiz comes in. September 12, 13, 14, we are conducting, MJ Malar is conducting a HPB nursing certificate course. It's a 3-day course, and that is being conducted in which direction is that? Muttamil Mandram. It's quite a big thing, and we are expecting at least 50 to 100 sisters to be involved in it, and Vidya and Anita are the organizing secretaries. Madam is organizing chairman. So it's a the thing I want you all. Okay, that's not the interesting part. The interesting part is we have a cultural evening. That is on Saturday. We'll have a cultural evening of 3 to 4 hours there, and it is a combined hospital employee, everybody included things. So I thought of few things. Actually, we discussed it with you and others. Now I thought we done similar things in the institute which I worked earlier. What we have done is, what I plan to do is divide the entire hospital employee group, is doctors, nurses, ward personnel, and everybody into 4 groups. Okay, one group is led by, say, Suman, one by Maria, one by Darsha, and one by Danny. Okay, it will be lottery. We put all the names and do a lottery so that you'll get, then you form your own cultural group. From your group, it's a competitive thing. You devise a dance, mime, mimicry, whatever, and start preparing from now itself. We have 1 month time. This hall will be available for rehearsal. We'll also plan to have a dance tutor to help you, and then there'll be costumes, etc. So let the festival begin from now. We all enjoy doing those things. And it's a real competitive thing. You have a name for your team, you have a name for your team, and so on and so forth. It will be just fight. And we show there, and that will be on the Saturday evening, followed by dinner, where everybody is invited. Vidya, you want to add something more? It's an academic thing, but it's also a cultural thing where we have our own entire people. So you need to choose, you people have to choose your dancers, singers, theme, etc., etc. Vignesh, my good friend, will form a theme for this cultural thing, and he'll let you know how the program goes. Vignesh, we will discuss that, and you have to get it going next week. Yeah. Then I'll hand over to Swarna for the quiz.
Many announcement. So before that, believe it or not, 26th of August will be the 25th episode of Karkande. So we plan to have a special, commemorative session, because you all will be busy with your NABH assessment. There won't be the usual thing for which you have to practice. But instead of that, we'll have some special guests. A few of you will reach out to you to come on stage and speak that day. Guests will also speak. Then we'll have edited videos of all the recordings that we have done till now. And the few of them which we could not record, we'll have some photographs. And then we'll be reaching out to you. Humaira's coordinating. So Humaira will be coordinating with you. So we'll have representatives from doctors, nurses, physician assistants, and secretary staff, as well as housekeeping and others. So we'll take some sound bites from you, and then those videos also will be played. So same 1 hour, but full relaxation. No need to worry about how you are going to perform on stage. But spread the word, and hopefully we'll have and most importantly, we are going to have a poster competition, the theme of which will be Karkande. Any type of team is allowed: single, 2 people, many people, combination doctor nurse, combination of any combination. Any number of entries are allowed. So we'll go through the entries, and the top 10 entries will be on display in this hall. And the guests that we are inviting on that day, they will be the judges, and the first 3 people will get a prize. Then other than that, we are going to have form a small committee which will go through the recordings of all the previous Karkande episodes, and they will vote for the top 3 episodes. So the first, second, third, like that. And those teams, the full team, we will let you know in advance, and we request all the team members to come on stage and to receive the prize from the special guests who will be there. Any questions? Okay, 26th August is a Tuesday. Our thing is usual 1 to 2 p.m. Tuesday. I think we don't need a calendar, right? 1 to 2 p.m. Tuesday means Karkande. So the same thing, 25th episode will come on 26th August. So please spread the word.
I don't have nothing to say. Maria Maratrang. I think last 1 month, my department is the topper in code blue. Not 3-4 patients. Why I wanted to tell you is, all my patients, they were revived and they went to the ICU. Thank you, Code Blue team. It doesn't happen everywhere. I've been in many. Yeah, that's problem. The success rate for Code Blue is defined in NHS is not reviving, not living to 100 years. It's just shifting to the ICU. That's called success. So success rate for NHS in the UK is 20%. For my patients, 100% Malar. Thank you.
So I wanted to mention one point. So usually for a particular number of inpatients, multi-specialty hospital, Masathukku there will be a particular number of Code Blue calls happening. Okay, and I'm part of this Code Blue team, CPR committee, morbidity, mortality across all our 3 hospitals. The lowest is Malar. There are. Why? Yeah. Absolutely. I think that is a very, very, very important reason. So number of arrests romba kammi. Malarla number of arrests romba kammi. Yena you all identify the deterioration much earlier and escalate it and get them to the appropriate whatever intensive care or proper treatment so that they don't deteriorate further and get into a med call or Code Blue call. So the credit goes to you all.
Project on this and presented in 40%. Why Code Blues are less because of news. Thank you.
So keep the good work.
Good afternoon, everybody. So when I wanted to write a prelude for the quiz, I thought I'll have synonyms of excited. But then there have been too many excited news, so that I don't have a prelude. Let's go ahead with the quiz. I put this quiz together because there is an NABH audit coming up. I know that your knowledge with infection control, hand hygiene has all been brushed up. So I'm looking forward to all the questions being answered. Kindly read the questions and look for tricks. And please raise your hands to answer the question. Do not yell the answer. If you yell the answer, nobody gets a prize. Okay? The first question is, which of the following is not one of WHO's 5 moments of hand hygiene? Only... Okay, that's the right answer. You can take your prize system. It is recommended to do hand hygiene before putting on the gloves, but it is not one of the 5 moments of hand hygiene by WHO. Sister? Next question. In the ICU, what's the primary purpose of prone positioning an ARDS patient? Is it to improve cardiac output? Yes, sister. That is the right answer. Next question. What is the minimum percentage of isopropyl alcohol recommended in the hand rub for hospital use? Is it 40, 50, 60 or 90%? Yes, Anita sister. 60 is the right answer. It should be at least 60%. To answer Maria sister's question, it is 70% in the hand rub that's used in the hospital. But it should be at least 60% to start with. It is not 90% because 90% will cause denaturation of the microorganisms. Which factor reduces the effectiveness of alcohol-based hand rub? Is it warm temperature, visible soiling of hands, or light rubbing motion, or dry skin? If hands, please. Maria, sister. Okay, that is the right answer. Next question. After touching a patient's surroundings without performing hand hygiene, which organism was most frequently found on healthcare workers' hands? Show of hands, please. Can you abbreviate MRSA? No, that's not the right answer. It's an organism. You are right, you can try. Yes. Question. Which of these infections requires soap and water hand washing even if an alcohol based rub is available? That's the right answer. இங்க பார்த்து படிச்சிருங்க. Clostridium spores are resistant to alcohol based hand rub, so you have to wash your hands. Next question. Which part of PP should be removed first after patient care? Yes. You sister, yes. That's the right answer. To the next question. What is the recommended method to clean a blood spill on the floor? Next. That's the right answer. Next question. How should you dry your hands after washing them? Should you use reusable paper towels or leave them to air dry? Disposable paper towels or electric hand dryer, or use an alcohol hand rub to dry? That's the right answer. To the next question. What is fomite? The term fomite refers to what? Is it a droplet particle, a contaminated surface or object? Is it an airborne spore or a sterilization process? That's the right answer. It's a contaminated surface or object. Fomite basically means that it belongs to the patient. Anything that the patient uses, touches, or is around the patient. That's the last question. Thank you so much. That's been my time.